Welcome to our live webcast, Everything in Primary Care Practitioner Needs to Know About Joint Replacements. Thank you for joining us. My name is Juliet Davis, and I'll be the operator for the presentation today. Before we get started, I'd like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you'll see a text chat window. There's a large window which holds all your sent messages, and a smaller text box at the bottom where you can type in your questions. To send a question, click on the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order which they were received, will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event evaluation. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. We are joined today by our speaker, Dr. Paul Lombardi, of the Medical Director of Joint Replacement Surgery in Morristown Medical Center. He's a fellowship-trained and board-certified orthopedic surgeon, specializing in hip and knee replacement. At this time, I'd like to turn the microphone over to our speaker, Dr. Lombardi, for opening remarks.
Thank you, everyone, for joining the webinar from Atlantic Health for joint replacement for primary care physicians. It was a beautiful day today in northern New Jersey, so I hope most of you had a chance to enjoy that. Actually, the initial title was supposed to be what primary care physicians really need to know when it comes to joint replacement. You know, the real details that are useful in the office when talking to patients and when planning surgeries, how to do clearances that make sense to you and make sense to us, the communication piece. So I want this to be that kind of bare bones details about how to indicate a patient properly and how to have the surgery done in a safe fashion with good communication between the orthopedist and the primary care physician. Really what motivated me to do this talk was I remember a primary care physician when I first started practice 22 years ago, Ron Safrida from Mendham, who said to me, he introduced himself, and I said to him I was a new orthopedist on staff, and he said to me, Paul, here's what an orthopedist needs to know about primary care. And he gave me the details, which was, when I call, just take down the name, don't ask me what the insurance is, don't ask if you have an MRI, just tell me that you'll take care of it and hang up the phone. So that was good advice and good bare bones information, so that's what I was hoping to do tonight. So first, I have no financial disclosures. I am not a consultant. I do not teach for any companies, so that I have no strings attached in any surgeries that I do or any implants that I provide. So why is joint replacement important in our practices? Because right now, joint replacement is the largest number of DRGs in the Medicare system by far, and is continuing to grow. So that this is something, as time goes by, and I'm sure you're seeing it now, in your offices, you're being probably inundated at times with knee pain and hip pain. And if we look at this slide here, we're looking at the projections for total knee replacement and total hip replacement as years go by. And right now in 2021, if you take that out 10 years, which hopefully will be still within my career lifetime, you're talking about a doubling, if not even tripling, the number of cases that need to be performed. So this is something I'm sure we're all going to have to be dealing with on a regular basis. And the demographics are changing. So I remember when I first started practice, not really practice, when I first was in medical school and in training, that you had to be close to being disabled to get a joint replacement. It was really meant for the elderly populations. And now what we're seeing, and what this slide represents, is the ratios of who's getting them now and who's going to be getting them in the future. And as we see, now this slide is somewhat older information, but this is actually representative of what's going on now, which is that the growing population for joint replacement is in that 45 to 64-year-old range. That's where joint replacements are really starting to grow as far as the numbers, because people don't want to be hampered by these things anymore. They want to play tennis and play with their grandkids or whatever it is they're looking to do, and nobody wants to deal with that disability anymore. So what has happened recently is that joint replacements were removed from the inpatient-only list. And why this is very important is now they're all going, total hip and total knee are going to outpatients, okay? And it's been projected that in a very short period of time, roughly 50% of joint replacements for hip and knee are going to be done on an outpatient basis. So this is something that we all have to get prepared for as orthopedists and primary care physicians when we talk to our patients. And of course, we're looking to really spend our dollars wisely, right? So right now, the reason why Medicare is very interested in getting these on an outpatient basis is because only about half, roughly half of the dollar spend is on the hospital stay. And if that hospital stay is an outpatient stay, that number, instead of $13,193, would be significantly lower. But then we're no longer going to be using skilled nursing, inpatient, even home health. We can reduce our readmissions so that by doing it as an outpatient is going to be a significant savings to Medicare. This is a projection from one of the orthopedic societies regarding the projected outpatient total joint growth. And you see in 2026, which is not that far away, roughly 50% of the hip and knee replacements performed in this country will be done on an outpatient basis. And why this is important as primary care physicians is because you're the ones who sometimes receive the questions from patients. They see the orthopedist and they're very polite, and sometimes they don't ask all the questions they should ask, and they're on the phone to you asking, well, is outpatient safe? What about my medical problems? I don't have anybody at home. These are questions that are going to be asked in your offices as time goes by. So let's start once again with this bare bone information. Okay, what is it that we all need to really know? Not just slides about anatomy and about surgical procedures and that horrible thing about DVT, the factor 10 pathways, right? What are the questions you need to really understand as primary care docs? What do I need to know as an orthopedist? That's your concerns, okay, when I see these patients, right? So first, how do we get these patients to avoid needing a surgery? Okay, and I have this discussion all the time in my office. Just because I have a hammer doesn't mean everybody's a nail. So we need to understand how to keep patients out of the operating room, right? So we start with the simple things. Low-impact exercise program and weight control. Very simple. Non-steroidals. Now this question, okay, is in black, is actually a question I put out to the audience, okay? And it's a rhetorical question, I guess, and if anybody has an answer, please put it in the dialogue box, which is Celebrex is a very effective anti-inflammatory. And as an orthopedist, in our literature, we actually recommend that you can use it with antiplatelet therapy or factor 10 inhibitors because Celebrex does not have an effect on platelets. But many times when I have done this in the past, this will generate a raised eyebrow from primary care docs and cardiologists, rightfully so, about whether or not this is safe. And this is a question I've had a debate on with many primary care docs, and I'd be interested in knowing what some people feel about this particular topic. Cortisone injections and hyaluronic acid injections. Right now, these are the two standard of care injections in orthopedic surgery. Cortisone, we always start with a cortisone injection, because cortisone works in everyone. 100% of patients will get some relief with cortisone. It's just a question of how long. And as a best practice, every 6 months is really what should be done for patients when it comes to a cortisone injection. Now, there are times when I break that rule, and that's for that 85-year-old who comes in and really doesn't want to have a surgery, and I kind of break the rules a little bit, and that's okay. But certainly for long-term care, it really is every 6 months. And then if cortisone is ineffective, the next step would be hyaluronic acid. And hyaluronic acid is effective in our literature in about 50% of the patients who receive it, get 6 months worth of relief. So that's why we always start with cortisone and then go to hyaluronic acid injections. And in my opinion, I see no reason why primary care physicians can't perform these injections in your offices. I think that it's non-operative care, it's completely appropriate, and quite frankly, can be a revenue producer in your offices if done correctly with regard to inventory control for hyaluronic acid. This is a revenue source that is completely appropriate, in my honest opinion. When you get past cortisone and hyaluronic acid, we get to what I would call we start to call a little bit of science fiction in orthopedics, which is PRP, platelet injections, stem cells, radiofrequency treatments, okay? And these injections are not considered best practice in orthopedic surgery at this time. These injections are very expensive, running into the thousands of dollars. And the literature on this is just not there yet. And how I have some credibility with this, and I talk about this with patients all the time, which is I could probably give up surgery and probably generate more revenue by doing these injections on a regular basis rather than doing surgery. And it just doesn't work. It just is not there yet as a regular treatment. Now, that being said, there's no harm in these injections. These will not cause any degradation of the joint. And also, RF treatment, by the way, that's when we use a radiofrequency probe to numb one of the nerves around the knee to provide analgesia. Well, all of these particular treatments are very expensive with no real science behind them, and I don't recommend them on a volume basis. So we try to avoid it, but who should have one? Okay, who really should have a joint replacement? And I'm sure as primary care docs, you're asked this question all the time. Do I need a hip replacement? Do I need to have my knee replaced? And x-rays are for diagnosis only. The answer to that question as to should someone have a joint replacement is not on the x-ray. The x-ray is there only for diagnosis. It's all about lifestyle. And lifestyle is a very independent thing. What's lifestyle to me is not lifestyle to one patient. It's different from the lifestyle of the patient in the next room. It's does the arthritic nature of this person's problem interfere with their ability to work, to carry on their relationships, to play with their kids, and the type of things that are what it's all about. And that question is all about lifestyle. And I always turn that question around to patients when they ask me, do I need one? In my practice, I very rarely tell someone they need a hip replacement. They need a knee replacement or a hip replacement. Because on a rare occasion, yes, someone comes in and has some horrific deformity that's dangerous, but that's rare. And it's on a very rare occasion that I tell someone, you should have a joint replacement. So now, this is really to the meat of our discussion today and what it is that we want to try to accomplish, which is who do we need for risk stratification and for optimization, who are the patients we have identified by literature that are a problem? And it comes down to really these four things, okay? BMI, smoking, diabetes, and sleep apnea. And we just go over them each briefly. So in our literature, BMI greater than 40 actually is now considered the standard by which we actually will draw back our indication for joint replacement. And this has been shown through multiple studies that these patients are at just a much higher risk for all kinds of complications, readmissions, infections, DVT, and insurance companies now, especially Blue Cross and Blue Shield, it's an automatic no. If they see 40.1 listed as BMI, it's an automatic no. There's no debate. There's no discussion. It just automatically gets canceled. And these patients, I will actually have a discussion about, I think it's indicated to discuss medically supervised weight loss. From the selfish orthopedic standpoint, I want patients to be able to get their number down below 40 in a safe way, and that could be done with a supervised diet, not necessarily with any kind of surgery. And the surgery could be performed in a safe fashion, and then after the surgery, the patient has a choice whether or not to make those kinds of changes to their lifestyle where that weight loss can stick. But there is a role for medically supervised weight loss to try to get that patient down to a safe number. Smoking is one of the obvious ones. Patients who smoke at a much higher complication rate with regard to their wound management, infections, other medical complications while in the hospital. So that right now, most of my colleagues, including myself, will not operate on someone who smokes. And I actually, if I have someone who says they'll quit smoking, I actually nicotine test them prior to surgery to make sure that they actually did quit smoking prior to the procedure. Diabetes, as we all know, has become epidemic in this country. And right now, and this is something that I've actually had to have multiple conversations with primary care, is that 7.5 is now considered the number where anything higher than that is an automatic cancellation for increased risk of infection. And that's been shown by our literature. This has become such a problem that actually this is the small amount of primary care that I actually provide. I actually screen every one of my patients I indicate surgery for joint replacement. I perform a hemoglobin A1C. And these are in all comers, whether they're diabetics, pre-diabetics, or perfectly normal. And every month, I actually diagnose at least 1 or 2 patients with diabetes or pre-diabetes. And I have them screened, and my record was 12, an A1C of 12. A gentleman who had no prior history of diabetes and felt he was perfectly fine, and then had an A1C of 12. And he was grateful to find this out, but I have seen so much of this, that's why I've gone to actually pre-screen every one of my patients with the hemoglobin A1C. Sleep apnea, this is a very, very important diagnostic, very important diagnosis to exclude. Where this particular concern came from was, and we did this here at Morristown, which was if you put patients into a computer analysis and said, okay, who had a problem? Why did patients have a problem when they had no previous medical issues to speak of, but yet wound up having some sort of medical complication? What was the common thread that these patients had? Number 1, sleep apnea. Previously undiagnosed, untreated sleep apnea. So that in patients who look like they may be, patients who may have sleep apnea, we try to get them evaluated, and it is not, someone will not be canceled if they have it, if they at least start treatment. So if someone comes to my office and says, I probably do have sleep apnea, I snore, my wife tells me, my husband tells me I snore, I sleep all day long, as long as they get to the appropriate person to see them and start treatment, that's fine. We can go ahead with surgery. And this is just a slide to reinforce the issue regarding obesity. And the RRAT is a tool that is used to try to predict what patients would be having postoperative complications. And what we found in the stratification was that, once again, being obese was the number 1 reason why patients in their preoperative screen would have a medical complication. So DVT screening is an important part of any evaluation, okay? And I perform this on every patient to discover what is their risk stratification and what's important, okay? And what's the bare bones stuff we need to understand when it comes to this? It's not some bizarro slide with arrows here, factor 10A, factor 7, factor 8. That's nonsense, right? It's right here, which is, did this person have a previous DVT? Is there a family history of DVT? Recent history of cancer? Those are the three questions I ask right off the bat. And these three diagnoses, protein S and C, factor V Leiden, lupus anticoagulant, those are really the majority. That's 95% of the issues medically that I see in my office. And we make sure that we screen these patients prior to and make sure they have the appropriate recommendations from primary care or the hematologist to understand how we're going to treat these patients after surgery to make sure that everyone is on the same page. And these are the three diagnoses that we see most commonly that we need to really worry about. So this is a hot topic when it comes to patients who indicate for surgery. And one of the most common questions that I usually get on the phone with primary care docs is how do we manage their antithrombolytics pre-op and post-op, okay? And this is probably maybe the one slide, if you're going to pick out of the presentation to actually maybe download or to have, which is how long do you need to, what's the interval to discontinue various medications so it's safe to have first the joint replacement itself and to be able to have a spinal anesthetic. I'll get into the spinal anesthetic in a minute, but those are the two, and they really are the same. They really are the same number. But this is certainly what we need to understand when we're scheduling a joint replacement. Because what happens is if this person shows up to the preoperative holding area and says, "Well, I took my, I took my Xarelto yesterday," well, they're going to go home. I took my Eliquis yesterday. Well, they're going to go home. And obviously it sets up a huge disappointment, and so we try to avoid that. But this is the slide where we talk about how you need to discontinue medications prior to surgery. Number one that we usually have a problem with is Plavix, only because of the amount of time that it takes to be off it to be safe and the number of patients who take it. I particularly don't see too much Brilinta or Efficient. That's a little more on the rare side, but certainly Plavix is the number one medication that we see that usually gunks up the works in our preoperative evaluations. And actually, the one topic that's now come up that is very important is what do we do with patients who are on dual antiplatelet therapy or DAPT, right? Those patients who have coronary artery disease that is somewhat symptomatic, perhaps a patient had a recent stent or stents that are 3, 4, or 5 years old that cardiology or primary care wants to have them on their dual platelet therapy, which is Plavix and aspirin. The recommendations now are to continue the low-dose aspirin, the 81 milligrams, right up to the day of surgery is okay. But not 325. 325 is too much a risk of bleeding, but certainly 81 milligrams right up to the time of surgery is certainly okay to take for dual antiplatelet therapy patients. So the surgical experience itself. What are the details that we tell patients that primary cares need to know so that they could educate their patients? Okay? Because many times when we have our preoperative talk, they're told, yep, you need to get your medical clearance from your primary care doc, and they come to your office with the medical clearance, and they bounce these questions off of you, right? They want reassurance to know that everything is going to be okay, and they're going to look to you for that. So that's why I wanted this to be this kind of these bare bones questions that we're going to answer, because these are the questions you're going to get asked, right? So the surgical experience itself. And this is the tempo of questions, and I put it in this order, because this is how my preoperative discussions go. I tell them it takes about an hour, right? That's how long the surgery takes. Spinal anesthesia is the standard of care. No longer general anesthesia. It's actually quite rare to have general anesthesia. And in centers like the Hospital of Special Surgery or the Roslin Institute, if a patient walks in and electively says, you know what, I know I was going to have a spinal, but I really want to have a general instead, and they insist upon it, they're actually sent home. That's actually how important it is to have a spinal anesthesia, because it decreases the blood loss at the time of surgery. And probably more importantly, it's been very well documented that spinal anesthesia will decrease DVT risk over time. So it's very important to have a spinal anesthetic. As soon as the spinal wears off, patients are up out of bed and are mobilized either with nursing or with physical therapy. And we use something called the Kansas City score. So, and I want to talk about this because this is a frustrating part sometimes for patients and families, because they'll say, well, you know, I had my joint replacement and I was sent home, and I don't know if I could take care of myself, I have nobody at home, etc. And in our preoperative discussions, we always tell patients, we screen who lives with you, do you have help at home? And if the answer is no, we say, okay, is this somebody who could stay with you a night or two to make sure that you're okay? So every single patient is screened in that way to make sure that there's somebody there for a few nights when they're home, because they don't leave the hospital unless they're independent. And that's where the Kansas City score comes into play. So basically what that is a patient gets a certain number of points for various things that they can accomplish. Getting out of bed gets a certain number of points. Walking a certain number of feet. Being able to navigate stairs. Get out of a simulated car. Get out of a simulated bathtub. And those points are totaled, and if the patient scores greater than 19 or 20, we know that they are safe to go home. If that score is below that number, we know that we need to we cannot send them home as an outpatient, or we need to keep them overnight. And after a night or two, if they're still, their score hasn't gotten any better, then we have to consider an inpatient rehab stay, which is quite rare, but that's what the Kansas City score comes in. That's our objective guidance to make sure that we're doing the right thing by the patient. Because I certainly, you know, in the converse, I don't want to send someone, I'd rather send someone to rehab than send them home to an unsafe environment, right? So that's how, we will not send somebody home unless we know that they're safe. No wound care is required. We use a skin glue now, so there's really no bandages to care for. There's no real acute nursing needs, so that we have all but abandoned home nursing for the simple reason there's no nursing required. So we no longer use home nursing. No inpatient rehab stays routinely, okay? Avoiding home PT and nursing. And, you know, this is I have up there as a thorny issue, because many times patients think that, you know, more is better. More is better. And what we've discovered, and particularly for the anterior approach hip replacement patients, and I'll get into that a little bit later, but certainly the anterior approach hip replacement patients don't do very well initially if you send them to physical therapy or have a home physical therapist work on them. It could actually make their swelling and make their pain worse. And I have this discussion all the time with patients, but many times, you know, not every patient remembers it, not every family remembers it, and it could be a difficult issue because they feel that they're having care withheld because they didn't have therapy or home therapy prescribed to them. Many times they'll call primary care physicians so that you can provide it. But that is the reasoning behind that. And there's actually literature to support this, that for the first month, really, after anterior hip replacement, we don't really do physical therapy. A home exercise program is more than enough. And then when they come back and they want on visit, that's when we talk about physical therapy. And so that's for the anterior approach only. Posterior approach, we do therapy right away, but for the anterior approach patients, we like to wait at least a month. And for total knee replacements, we start outpatient physical therapy right away. 2 times a week for about a month, and 2 times a week is a sweet spot. Anything more than that, 3 times a week or 4 times a week, there's just not enough rest built in. Patients actually develop more swelling, develop more pain, and it becomes more arduous for them. So the anterior approach, hip replacement, which is something that's becoming much more popular. You can use a special table. You don't have to use a special table. You can use X-ray. You don't have to use X-ray. But certainly, these are the type of granular questions that patients ask me, and I'm sure that they ask primary care doctors. You don't have to use a special table. You don't have to use X-ray. One of the benefits of anterior approach, less dislocations, easier to establish leg lengths, and you don't cut through any muscles. You go through planes. And there's also, the posterior approach, which is the tried and true, 30 years worth of results. The posterior approach carries with it hip precautions. That's the traditional 90-degree rule, high toilet seat, pillow between the legs while sleeping. That's for the posterior approach. For the anterior approach, that does not apply. But it's very important. There's absolutely nothing wrong with the posterior approach. I'm probably 80-20, 80%, 20% anterior approach to posterior approach. I still do a fair number of posterior approach hip replacements. There's absolutely nothing wrong with it. If you put an anterior approach and a posterior approach side by side, and after a year, you really can't tell the difference. The only difference is in that first month or two when patients are recovering. So that if it's recommended to a patient to have a posterior approach, and they see you in the office and they're all disappointed, this is what my doctor told me, there's absolutely nothing wrong with that. There is no harm at all in a posterior approach. So a slide I perhaps forgot to put in here. So that was anterior approach hip, posterior approach hip. Total knee replacement is total knee replacement. There's really no multiple ways of doing it, with the exception of now robotics. So what is the role for robotics? And in my opinion, as someone who performs joint replacement, on a routine basis, the technology just isn't there yet. There's absolutely no literature to support using robotics with respect to outcomes. There is no paper yet written that demonstrates a robotic hip replacement or a robotic total knee replacement is any better than it's done the traditional way. When you look at patient satisfaction scores, rates of revision, the X-rays and measurements, and as time goes by, I'm sure the technology is going to get better, and there are certain indications for robotics, patients who maybe have certain congenital deformities or their anatomy has been disturbed by previous trauma, and the normal anatomical cues that are needed to perform the replacement just aren't there. Certainly, robotics can be a game changer for certain subclasses of patients, but on a routine basis, there really is no benefit at this point to robotics. So the implants are pretty much the same. That's a total hip replacement on the left and a total knee replacement on the right. So what is it that primary carers really need to know? So right now, the standard of care for hip replacement is a titanium stem, a titanium socket, a plastic liner, and a ceramic head. That is now the standard of care. And we've gone through metal on metal implants, which turned out to be a problem. Ceramic on ceramic turned out to be a problem. Ceramic on plastic, or ceramic on poly, really seems to be the sweet spot with regards to wear, and is now considered the standard of care. Titanium femoral stems are for the non-cemented type, which are the majority of replacements. And then for patients who have significant osteopenia or osteoporosis, we actually do still cement these patients. And once again, there's absolutely nothing wrong with a cemented hip replacement done for the correct indication. Hip replacements that are well done, literature on implants put in the 80s or 90s demonstrate 25-year excellent results. so far. They tend to last a little bit longer in women than in men, because men do stupid things, I guess. And so that's hip replacement. Total knee replacement really hasn't changed very much over the years. It's a metal femur articulating with a plastic polyethylene. And the real changes to total knee replacement have really been in technique, surgical technique. And the pain management now for hip and knee replacement has really been the game changer, and why we can get them to outpatient. We do various nerve blocks, we do various injections of pain medicines at the time of surgery. Our pain cocktails are much more advanced, not particularly reliant on narcotics, so that that's what's the real technology. Real technology change has not really been the prosthetic themselves as much as the surgical technique and the post-operative pain protocols. So post-operative course, in bold, bruising is normal. Every one of these patients have bruising, and this causes multiple phone calls. I'm still trying to figure out ways to show patients on our website pictures of what normal is like, but this is the number one question that patients will have, is this bruising normal? And they will call your office and tell you, I get this horrendous bruising, I think something is wrong, I have a blood clot, do I need to go to the ER? But bruising is absolutely normal. For 100 patients who call up with bruising, maybe one or two are patients that we are concerned about, usually wind up needing further care. So in post-op course, hip replacement, we talked about the precautions for a posterior approach. There is no therapy in the anterior approach for 1 month. We do PT if we do it for 1 month, and then we assess. Driving is right away for someone with a left leg. It takes about 2 or 3 weeks for someone with a right leg. And work, I really leave up to patients, but generally patients who have an office-type job, there's no reason why they can't be back at work in 2 or 3 weeks. A more labor-intensive job usually takes about 2 months. And various activities is really done on a case-by-case basis for most patients, but certainly there's no restrictions once they're fully recovered. And the one thing I tell patients not to do is straight-line jogging. That's for bend knee. We don't want you to sort of pound on those replacements and wear them out. Other than that, there's really nothing you really can't do. In total knee replacement, in the post-operative course, in the first month, extension is much more important than the flexion, so that patients and docs tend to really focus on how much the bend is. In the first month, I almost won't care how much the patient's bending their knee. I want to make sure they get full extension, because you can't manipulate away lack of full extension. And you can't go up and down stairs, you can't walk very well if you can't extend your knee all the way. So we really obsess in the first month about extension more so than flexion. Once again, we do PT for about a month, and then we really assess. The driving rules are the same as our work and various activities. Dental prophylaxis, that irritating question we always get asked, is still now 2 years after the initial surgery. This recommendation gets changed by the American Academy of Orthopedic Surgeons. It seems like every 5 years. I think we're almost at that point now to come up with another change. In my career lifetime, I think this has changed maybe 5 times. But currently, we are saying that dental prophylaxis, which is usually amoxicillin, a few grams, an hour prior to a dental procedure, is what's required. Why do we do this? This is a patient who came to me, just a terrible deformity, having difficulty with her job, having difficulty with just getting through life. Horrific deformities on x-ray. Here she is in the office. What you have to focus on in these little patient videos is not just their knees as well, and it's difficult to mask, but their facial expressions. Okay, they go from despair to hope. Oh, I already did that one. So why we do this? Oh, how'd that happen? Well, I guess you have to take my word for it that she's struggling. She's not walking uphill, but you can see generally that this patient just barely can make it down the hallway. Okay, 2 terrible hips, could barely make it down the hallway. Okay, It took her about, I'd say easily a good 2 minutes just to walk to X-ray that day. Okay, and that's her doing a little dance maneuver a few months after surgery. And certainly, every orthopedic surgeon has these videos. I am not special. But this is a demonstration of why I'm not an IT professional, number one, but it's more a demonstration of how we affect and deflect these patients' lives is why we go through all of this. It's why we struggle to get medical clearances and why we go through all of this. And I'm seeing this now that the pandemic is over. This person I'm seeing in the video is no longer the exception. Since everybody's gotten their vaccines, people are just coming out of the woodwork with these horrific deformities and neglect over the last 2 years. And not just orthopedics, I'm sure as primary care doctors, you're seeing neglected diabetes and neglected hypertension, neglected cancers that have developed. That's what we're seeing in the office now is patients like this. And once again, we're doing this for this patient. And the first thing this patient did when he recovered, and he was teary-eyed in my office, he went fishing with his father. That was the one thing he wanted to make sure he did after surgery. So I am finished. That is my presentation. And I hope people have lots of questions. Actually, I may need to have my support team come in the room because my computer timed out for me to look at questions. But certainly, I have one question that I want answered from this talk, which is, as an orthopedist, how do we improve the communication piece to get medical clearances in a way that's what I need as an orthopedist and can best be done in your office? That's a question I'd like to have answered if possible. So certainly, ask your questions. I'll be more than happy to answer all of them. Thank you.
Great, thank you. As a reminder, the text chat is located on the right-hand side of your screen. To submit a question, type your question to the small text box at the bottom. When finished, click the send button. Please note, due to time constraints, our panel may not respond to all questions submitted. And we'll wait for
I need to have Chris come in here just to, the computer timed out, where I need to have, to see the dialog box. Okay, can everyone still hear me?
Yep, you're good.
Okay, so first question I have, what do you think about AFL as an indicator for recommending surgery rather than X-ray features after trying conservative measures for 6 months? I don't know what AFL is.
Right below it, they corrected themselves.
Oh, ADLs. What do you think about activities of daily living as an indicator for recommending surgery rather than X-ray features before after trying conservative measures? Absolutely correct. That's what I was talking about before. The X-rays only give you diagnosis. X-rays are not meant to be in the decision-making tree to have a surgical procedure. And ADLs is what it's all about. When I was talking about lifestyle, ADLs is a huge part of that. So activities of daily living, putting your pants on in the morning, getting to the bathroom, getting down the stairs, getting to your kitchen, making breakfast, getting out of your house, getting in your car, and going someplace. That's ADLs. And that's what it's all about. When people can no longer do ADLs, yes, that's when you need to do surgery. So that's a great question. Thank you. Next question from the same person. Anything to explain in regards to level of bending of knee post-surgery and wound dehiscence? So wound dehiscence, if you look as a complication, is not particularly common following knee replacement. So that we don't really care much about bending too much in order for wounds to heal correctly. And now with the skin glue that we use, it's really a very good adhesive, and we have not seen any issues with regards to bending. On very, very rare occasions, patients have very complicated issues where we have to let the skin and soft tissue envelope rest before excessive flexion. But certainly, there's really no concerns that we have about letting patients bend as much as possible. Next question. Good questions. What helps you make the decision of anterior versus posterior approach for hip replacements? Okay, excellent question. So what I'm looking at there is what's on the x-ray and the patient's body habits. So on the x-ray, what I want to make sure the patient doesn't have is previous hip surgery or some sort of congenital anomaly, or perhaps there's just something about the patient's geometry on the x-ray that makes it much more difficult. My personal feeling is the approach that one should use should be the one that's going to give my patient the best chance of success. I can do an anterior approach on any patient, but if doing an anterior approach is more difficult than a posterior approach for the same patient, I'm increasing the chance the patient's going to have an inferior result. And that's the reason why I will guide patients either way. But certainly, the x-ray criteria is one. The second is body habits. And it's not about the number. Okay, it's not a cutoff number where if a patient is over a certain amount of pounds that they can't have an anterior. It's really distribution. What a patient has, what I don't like patients to have is a rather large stomach or a pannus that hangs, because what happens is the incision is right in that fold, in that skin fold, and I tell patients I will guarantee them 100% probability of developing a superficial infection. And we'll have to do antibiotics, perhaps even dressing changes, and a few prayers and a few novenas to hope that it doesn't go deep into the prosthesis. So that's really where the decision-making goes. It's body habitus and certain conditions on the x-ray. It's a very good question. Next question. Don't you use ultrasound to guide your injections? Most of us internist primary care people are not trained in ultrasound-guided intra-articular joint injections, just saying would need some type of training. And I certainly would be very, very happy to have an injection class at my office. It would be very simple to do. And here's the reason why you can't use ultrasound. You can use ultrasound for knee injections. You can't bill for them. Medicare actually considers routine use of ultrasound for knee injections to be fraud, if you can believe it. But I would be more than happy, and we can organize this through Atlantic Health, to have an injection class. It really isn't that hard. It's more intimidating to start thinking about it, but I could teach a room full of primary care docs on how to properly how to properly prep and inject the knee for both cortisone and hyaluronic acid injections. I'd be more than happy to do so. When it comes to hips, I personally don't inject hips. I have an associate who uses ultrasound. You can't inject hips routinely in your office. That requires some skill and extra imaging. But for knees, I would be more than happy to have an injection clinic to teach that. Great questions. Next question is, what about preoperative physical therapy? Certainly, that is most beneficial, and I would say preoperative activity. And the reason why not physical therapy is I'm being more practical here, in that many times patients, in their zeal to do physical therapy prior to surgery, will use up their physical therapy benefits. So what I tell patients is if they have access to a stationary bike or a gym, I actually give patients exercises in my office that they could do on their own. As long as they're doing something, that to me is okay. There are patients who are a little more debilitated. Actually, we'll give them actual physical therapy because they seem like they really need it. But instead of preoperative physical therapy, I would say preoperative, some sort of preoperative exercise is a better term. But really, stationary bike is really great. I really try to recommend that to patients pre and post-op if they could get to it. Next question. Is there anything that primary care physicians need to know about the surgical procedure and follow-up care in some specific patients? So for total knee replacement, not particularly, because it's really kind of the same approach. When it comes to hip replacement, the only difference, there's no difference in wound care. The only difference is for the first month, there are precautions for posterior approach. There are no precautions for the anterior approach. And once again, it's about the physical therapy difference. You can start physical therapy right away for posterior approach patients. For anterior approach patients, we just like to wait that first month. We want the wound to heal. We want the swelling to go down. And that's really the only difference there. Next question. Do you see more need for joint replacements with patients who are hyperflexible, i.e. Ehlers-Danlos syndrome, which is being picked up more frequently nowadays? I would absolutely agree with that premise. In the patient who we always thought was a little lax, I think there's a lot more Ehlers-Danlos out there than gets diagnosed. And those patients actually, they don't develop arthritis more than other people, other groups of patients, but they can be much more difficult to manage surgically because most patients, you put in their joint replacement and you do soft tissue tensioning, and you say, okay, that's about right. And those patients always stay there. Ehlers-Danlos patients are the ones where you put in your joint replacement, you think you have the soft tissue tensioning correct, and they loosen up over time. And, oh, you know what? I got to go back. I have to change the thickness of the implant, So you have to be very, very careful with Ehlers-Danlos patients, technique-wise, because those are the patients who actually will stretch out and develop hyperextension deformities after surgery when you know you were just at full extension. So that's a very good question regarding Ehlers-Danlos. Next question. Do you recommend weight reduction surgery before surgery if patient cannot reduce their body weight? So I think I talked about this a little bit. Certainly, patients are, when they're coming to me for a joint replacement, they're already anxious enough in the anticipation of the joint replacement surgery. And I try not to use the bariatric surgery route unless it's really necessary. That's why I try to get them to use the medically supervised weight loss first. And I do mention it if they feel they want to go for bariatric surgery, because the gastric sleeves and bands are obviously much less invasive than the bypasses previously. But you have a patient who needs to lose 80, 100 pounds to have the joint replacement, and you tell them just go home and lose weight. They're not coming back. And so they need some form of intervention, whether that's medically supervised weight loss or a bariatric procedure, because they can lose that weight within 6 weeks, get down to a safe number, and then have their surgery. But certainly, medically supervised weight loss or bariatric surgery, absolutely. I think there is more of a statement than a question, which is this person says, would definitely be interested in my injection clinic idea. So I hope that has legs, because I think that it's something, it's a great service to offer to patients. And like I said, not to say that it's a reason you should do it, but certainly it's a revenue source that's legitimate to recoup. And if you can, it's also eliminating a step. So you see a patient you know has bad knee arthritis. Well, go to Dr. Lombardi's office and he'll give you a cortisone shot. There's really no reason why why primary care docs can't do that themselves. I'm sort of stripping away the mysticism maybe behind what we do. But it's certainly, I'll be more than happy to provide that. Okay, is there any EBM that the joint above the replaced joint degenerates early. So I guess the premise of the question is, if someone has a total knee replacement, does their hip or maybe their ankle go on to develop arthritis as a result of that? Generally, we do not see that. I think what we see is so if a patient has a right knee replacement, many times patients will come in the postoperative course that their left side is maybe a little cranky. That's because they're relying on that left side now more to get through the surgical episode. But many times that uncovers is patients may have had some, if they had a right knee replacement, they have some minor left hip arthritis or left knee arthritis that they didn't even know about. And then the stress of that kind of, the stress after surgery then puts a little extra pressure, and then you discover it. You may discover arthritis on the opposite side that you didn't really know was there, but generally does not cause it. But something actually very important is many times patients will come to the office and say, I have bad knee pain. And they say, I had an x-ray and they told me my knee is fine, I want an MRI. What you have to examine is the patient's hip. Many, many times, very bad hip arthritis will disguise itself as knee pain. That's because the obturator nerve provides sensation to both the hip and the knee. And many times, patients with frank hip arthritis do not have any groin pain or hip pain at all. They just have knee pain. So that's something to consider when assessing the patients. And the last question is from this website people telling me I can no longer answer any more questions. So I guess we're finished. So it was a pleasure having this talk tonight, and I hope this was informative, and thank you very much for coming.
Great, thank you. On behalf of the Atlantic Health System Morristown Medical Orthopedic Surgery, I'd like to thank you all for your participation in today's event. You'll now be redirected to a post-event survey requesting your feedback. Please take a moment to complete the survey in order to receive credit for providing feedback and attending today's webinar. This concludes today's program. Thank you all, and have a great day, everyone.